Everyone see my screen okay?
Yes.
Yeah, perfect. I've got a lot of student midwives working with me at the moment, so I just want to make sure that they're sort of contributed to these case reviews. So Rhea helped me with this one. I just wanted to make sure it's not just me that's getting the credit for making all of these. But this is a really interesting case, and I hope that it sparks a bit of a debate actually, because if anyone's got any additional research, you'll see why in a second. I would really appreciate it. So this lady is a gravida 3 para 1. She had a miscarriage and one previous SVD in 2022. That SVD was also, but the baby was SGA, and she had quite significant preeclampsia. BMI of 30, 29 years old. She was a late booker. It said query 35 weeks on her booking, but she was actually 13. I don't know if there was just a lot of bad maths here, but yeah, 13 weeks at booking. At 21 plus 4, she had a routine anomaly scan, which was normal. And at 26 plus 2, she came into triage with a PV bleed of approximately 50 mils. 26 weeks, approximately 50 mils. Does anyone want to sort of have a wild guess as to what could be the cause of this? Anyone want to hazard a guess?
Cervical polyp.
Cervical polyp, yeah? Quite common. Anyone else? Okay, we'll move on then. So this lady, due to the fact that she is 26 plus 2, the midwives in triage assessed her. And on the fetal heart rate auscultation using a sonicade, they thought that they'd had a deceleration. So the obstetric registrar came in, did a speculum examination, and also did an ultrasound scan, which showed this lady to be breech and hydramnios with a fetal heart rate of 120 with a decel noted. She had a speculum examination and the cervix was found to be 1 centimetre dilated, but with no active bleeding at that point. She was transferred to labour ward shortly afterwards and was given steroids and started on magnesium sulfate in very, very record-ish time. She also had some borderline blood pressures. So as you can sort of see as the trace continues, 131 over 84, 139 over 85 and 140 over 87. Stats and resps and pulse rate were all reasonably normal. But at 10:35, magnesium sulfate happened. And I've just realised you can't see that, can you? But it says 10:44, she had an APH of 200 mils. Now, what's the recommended gestation that we would use a CTG for? Anyone know?
week.
Yeah, so at Croydon specifically, we do recommendations for a CTG from 27 weeks onwards, and that's recommended by Dawes Redman as well. So obviously when women are sort of 26, 27 weeks, from 27 weeks onwards, we would initially sort of use Dawes Redman. However, it can be used from 26 weeks if there is enough of a clinical indication for it. And it's basically determined by what the obstetrician requests at the time and due to additional risk factors. So we've got a lady that we can hear D cells on the sonicade. We can see them on an ultrasound scan. So that would warrant essentially a CTG. It's not something that you see very frequently because routinely we wouldn't necessarily put them on until 27 weeks as of sort of our guidance with Croydon, but also as part of Dawes Redman. But yeah, I just thought this one was quite an interesting one. There is a few more slides, but I just want to know anybody's impression of this. What would our plan be? Would anybody like to add anything? Would anybody like to immediately go to theatre? Would anybody just sort of sit and wait approach with this?
She has had Maxo, she's had steroids, so I just say we wait and watch.
Wait and watch. What's
Mhm.
your impression of the CTG be?
Well, I can't say why she's having the distress because they are unprovoked. So baby is having some distress, whether it's because of the bleeding, just giving time for the steroids, or yeah.
Yeah, so just to sort of be aware,
Mm.
the nice, even I don't know if nice guidance still use them, but the term unprovoked is one that we do try and avoid, because unprovoked, the definition is actually that there's sort of no reason for it. Whereas when a baby is decelerating, there is always going to be a reason that this baby is in distress. It's just our responsibility to kind of find out, or try to find out, why this baby is in distress. So we do try and avoid using the word unprovoked. Also, it's worth noting that the toko wasn't actually put on this woman. I'm not 100% sure quite why. I don't know whether it was due to the fact that her abdomen or her uterus, for example, was in a sort of in a different place, or not in a different place, but would have been difficult to sort of palpate and whatnot. So yeah, it is recorded in the notes as sort of not being put on, but I would have liked to have seen what was going on with her uterine activity at this point. But yeah, so how long do steroids take to work effectively though?
All right, how many weeks is this woman?
26 and 2.
All right, sorry, I was a little bit late. Okay, fine. Steroids take about 12 hours.
Yeah, and we should, in order for them to become actually effective, it should be the 2 doses, and after the second dose, please correct me if I'm wrong, Mr. Nagib, but I'm pretty sure that we would try and like to get at least 2 doses of steroids in a minimum of 4 hours after the second dose before they're fully effective.
Yeah, so we must say that the steroid will be optimum. This is different from effective. So will
Yeah,
be optimum after 24 hours. But from the time you give it, every hour it is doing something. How much is it the something? We don't have a quantification. But if we are thinking of that delivery is not imminent, then certainly to give the steroid. If you think you are delivering within the next half an hour to an hour, there is no point. But if you are thinking that you are delivering later than that, it is worth giving.
absolutely.
So it's not that we must not limit ourselves with the word 12 or 24 or whatever, because like every single analgesia, for example, let's say you give paracetamol. Yes, it might be the half-life is working after 3 hours, 4 hours, but it will work as soon as it is in the system.
Thank you. What's our plan then? Anybody want to give a recommendation?
So like we said, we just do the continuous CTG we started, observe the uterine actions, observe the bleeding, and the woman should be having a good IV access.
Yeah, absolutely. So she has got IV access. We're putting magnesium sulfate through. We've given the first set of steroids, and the plan is to sort of see how we go essentially. But bearing in mind that this is an antenatal CTG, we can clearly see that this is abnormal due to the presence of sort of decelerations. Yeah. So we continue. She's a little bit tachycardic, 97, and it very much varies depending on her pain level. So she was in some discomfort, but not enough to warrant any additional pain relief. So no additional pain relief was given to this woman at this point in time. She had an indwelling catheter inserted because the plan was to very, very clearly try and make sure that she's got good fluid balance recorded. They moved her to left lateral at around 11:30 just to see if these decelerations were caused by some sort of cord compression. But as you can see, actually the decelerations do continue following this. And at 11:40, although the plan wasn't for a category 1 at this point, she was consented for a cesarean section with the idea that she may need to move to theatre.
Just a quick question. Was there any discussion about the fact that she's so preterm and that argument of delivery versus potentially a little bit longer? There's quite a few research papers about decelerations in less than 28 weeks gestation, and especially if she's, right, I think I could be making this up, but anhydramnios as well, or she's or something. So you have got that risk factor anyway for such a preterm fetus, plus the fact you're going to add some stress onto it. But was there any other discussion about that sort of prematurity versus keeping in utero? Because if you deliver too early, it dies of prematurity. You've got that versus could we have kept it in a bit longer? Does that make sense? Fetus, you know what I mean?
Yeah, I think there was a big discussion that went on between the consultant was present on label this day. There was quite a big MDT discussion about it, just because obviously this is significantly abnormal for a baby of 26 weeks. And although there is a lot of research, 28 weeks and above is much more optimum. This isn't something that we could kind of sit on for a long period of time and ignore. Specifically considering that these decelerations at some points are lasting 2 minutes. And when I move to the next slide, I think maybe your opinion might change slightly about the delay in delivery. But yeah, there was definitely a long discussion about this, and the plan was to just try and get everything on board as soon as possible. I mean, the team on this case, big credit to them, because that she was transferred and steroids and magnesium sulfate was given within about 10 minutes of her leaving triage. So it was well escalated, and the plan was to sort of, I guess, see if there would be any changes or sort of room for improvement. But yeah, and the anhydramnios, there was no record of Schrom, and I believe they did do a what's it called? My mind's gone completely blank.
Amnisho.
Thank you. Amnisho, and it was negative, I believe, as well. So the fact that this baby, that's another risk factor just to add to the mix. She's got previous SGA, previous PET. Although the blood pressures aren't sort of to give medication just yet, we're bearing that in mind as well. So anhydramnios, this baby's clearly got an issue in utero. APH, what are we considering? The fact that she's in some discomfort as well at this gestation, and the fact that the CTG is significantly abnormal. When you add all of those risk factors together, is this baby actually better off staying in utero?
So the answer to you, Sorsha, is the discussion has happened, and as mentioned, the balance between and the fine line between keeping this baby in, knowing that it is, I don't agree with the statement of grossly abnormal or massively abnormal in this case, because we don't know what is normal, what is abnormal in a 26-weeker. So we cannot say it is abnormal and massively abnormal or grossly abnormal, because deceleration, as Sorsha mentioned, is known in 26-weeker. And if we add on top anhydramnios seen on ultrasound, you will have more deceleration with contractions. And the fact that there is an element of 50 mils of blood, whether this is complete blood or this was blood stained liquor, having seen that there is no liquor, then the fact that she's 26 weeks and delivery of the baby will be like as if also similar to keeping it in, will be as harmful as well, because baby out at 26 weeks might not be the optimum. And as I was in St. George's in many cases, and even the fetal unit wouldn't even scan some babies till 28 weeks. So the situation is a very, very, very fine line and a very early gestation, which means that we are in, if we deliver, we are doomed. If we don't deliver, we are doomed in any case. And yes, it is a, yeah.
Thank you.
Perfect. I'll move to the next slide here. Any additional comments?
Is it reported she's having uterine activity at all?
No.
So she's comfortable?
She's not comfortable. She's in pain, as in discomfort, but she's not, from what's recorded, it's not, it's discomfort. It's not significant pain. But also, this is one of the key messages I want to bring out of this trace as well, is the fact that there's no record of an abdominal palpation on her records. So we've got a 26-weeker with very much repetitive decelerations, and we're clearly concerned about the plan of care for this baby and for this mother, and there is no record of abdominal palpation, so no record of uterine activity.
No, I think there was, Cara, there was record of abdominal palpation and feeling of contractions, and
not by the midwife.
Not by the midwife, it is by the obstetricians.
Yeah.
And the obstetrician mentioned clearly that the pain is coming and going, most likely contractions, but very very subtle contraction. As she says that she is comfortable, it's not very painful. So there was a mention about it.
But as
quite a valid point, isn't it? Because at 26 weeks, we're not necessarily going to be expecting her to have strong contractions to stress this fetus out.
Yeah, exactly.
Fetus. So even that mild abdominal pain may be causing this fetus distress. So it would have been really interesting to see if she was sort of mildly contracting over 2 to 3 and 10. That would sort of, it would complete the CTG, wouldn't it? Here.
Yeah. Yeah, absolutely. The thing is, as well, is I don't know why there's no documented reason why the TOCO wasn't put on. It's put on in the next slide, which you'll see, but for this entire period of time, I'm not quite sure why it wasn't placed. And that's mentioned in the obstetric documentation that TOCO's not on. I believe that it was then put on following discussion with the obstetric team.
The TOCO was not put on because it was extremely difficult to find the fetal heart. So from the documentation of the obstetric team, you will find that to get a trace at all in a 26-weeker with SHROM was like finding a pin in a hay. It was like not so, and it was breached. So it was that the CTG transducer was put high up. So that's why till the time it was captured as a CTG, and then the TOCO was, like, was a nightmare to put as well, because it was very difficult to keep a CTG on.
Thank you. I think just worth noting, obviously, I've clearly missed that in the obstetric documentation about the palpations that were done. But yeah, for all of the midwives that are on here, I think I stress this on a daily basis on my ward rounds, as well as, on all of the study days, and a lot of the cases that we review on a Tuesday evening, that abdominal palpation is one of the things that seriously needs to be documented, even more so in this case. And from the research that I've sort of read between 26 and 28 weeks, I wouldn't say there was an abundance of it, because people don't tend to use CTGs very frequently between these gestations. So although if we were to look at this and she was 28 weeks, we'd say abnormal. If we're looking at it from 26 weeks, we kind of have to go by national guidance, so like NICE and FIGO and whatnot, and the fact that actually there is argument there as to, you know, what happens before 26 weeks. And actually, if we were to put a CTG on somebody that was 23 weeks, would we also see D cells? You know, we may not deliver at that point, but it's all about sort of weighing up the balance of additional risk factors and whatnot. So this continues. At 12:45, the CTG is reviewed and the plan is to observe for 30 minutes with a plus or minus of caesarean section following. Mum's sort of pulse is 97, so she is a bit tacky. Temperature's normal, she's respirate of 20, so we know that she's probably in a bit more discomfort now. But blood pressure kind of on the normaler side. But yeah, and then pre-meds were given in anticipation of theatre. Anybody agree or disagree with the plan?
No, I agree. As long as I think, like you said, you mentioned it's quite a good MDT that's sort of collaborated here. You've got, and I think that's what you need, especially, well, for every case, obviously, but especially with a preterm as well, because you're anticipating this neonate very differently when they come compared to a term baby. So having that sort of MDT support throughout, I think will be really beneficial. And I think, yeah, the CTG, like we said, it's not going to get any better, and you're not going to do anything. So I think that's sort of the only other outcome. But it is an interesting case to review.
Perfect. So at 13:35, she has an examination and is found to be 1 centimetre dilated. Liquor is now draining, and it's very blood stained. So at 13:40, the decision was made for a caesarean section. Blood pressure 131/78, pulse of 88, and I think that says SATs of like 96% at that point, no respirate or temperature. So yeah, we moved to theatre. Unfortunately, there was quite a lot of difficulty with getting this fetal heart rate in theatre, and I think what we possibly were picking up in those very, very small lines that you can see was maternal pulse. But she went in at 13:55, spinal at 14:11, and delivery within 11 minutes after that. Anybody want to guess the APGARs and the gases of this baby? I'm not letting you have this one unless someone makes a guess.
Serial 7.11, 7.23, basic cess probably about 6 or 7. APGAR, I reckon 6, 7, 7, maybe. I don't know how it's going to turn out. You've got the neonates there, so.
Yeah. Anyone else?
Low APGARs, I think. I'm not so sure about the blood gases, but I would expect them not to be good.
Okay. This baby had APGARs of 3, 7, and 8, so Saoirse, you're pretty damn close. Venous pH of I think they were taken from the same vessel, to be honest with you. 7.10 or 7.11, base excess of a -11.9, and a lactate of 11 or 10.5. This baby was intubated at 3 minutes of life and transferred out to a tertiary unit at 12 hours of life. There was abruption noted behind the placenta and yellow liquor suggesting chorioamnionitis. And I've actually got the placenta results for this one. There was a retroplacental clot in keeping with the clinical history of abruption, maternal vascular malperfusion, accelerated villus maturation and infarction, high-grade fetal vascular perfusion, and early acute chorioamnionitis. This woman had no report of SHROM at all, so it must have been discreet. But then, you know, it could have been very easily confused with discharge. But yeah, yellow liquor was one of the main ones. Chorioamnionitis can kind of confuse me, but I guess with the gestation that's sort of 26 weeks, you don't see it very often. But obviously, when we see chorioamnionitis in sort of a term fetus or a much later gestation, we normally see a rise or raised baseline for gestation with no sort of preceding deceleration. So the fact that this one's kind of thrown a curveball in the works is quite interesting, I thought, because it's kind of the opposite of what you would expect. Although there was possible sort of fetal infection and whatnot, chorio was not one that I had that was immediately one that popped to mind. But now we know what to look out for if this was to sort of come up in the future, really. But yeah, abruption was the primary cause of the bleeding. And yeah, I mean, I think the gases kind of show you that as well. This baby was working quite hard in utero to keep going.
I mean, fair play to the fetus, because if you are abrupting, it's held on quite a lot, didn't it? Given it's quite high. That's quite an interesting case as well, given that you're pretty much reviewing an abruption as it occurs, but yet minimal uterine. Sometimes we say you can see uterine active like irritability, but yeah, it wasn't, was it? So I think that's a really good case. Did she complain of backache or anything else? Just as she was.
I'm not 100% sure, but I don't think so.
No, she didn't. And also, we want to differentiate because this is an area of debate where people throw the word abruption. The word abruption has a spectrum, and sadly, everything that is having some bleeding is called abruption. And the abruption of 5 mils, and the abruption of 500 mils, and the abruption of covular uterus and 3 liters are put in the same bag. And the clinical picture of an abruption is very different. Different from concealed abruption, different from overt abruption. Abruption is a big thing that people don't understand fully how to classify. And I find sometimes while I'm doing risk, people throw the word abruption right and left and center. If we are saying it is a small clot behind the placenta, you can manage abruption conservatively. And you can manage abruption in a way that to continue pregnancy, whether you are 26, 28, 34. In many cases that we had in Croydon and in any other places, we had ladies coming with 500 mils blood loss. We had ladies coming with a liter blood loss. And then after giving steroid and the bleeding stops, and on the balance, we stop and wait and let the steroid work. So we need to have, as we say in all our CTG meetings, a bigger picture, helicopter view. Managing a CTG in the CTG meeting is not what we require. Managing a CTG within the context of a clinical case is the most important, and that's why a bigger knowledge. CTG is only one piece of the puzzle, 1/10 of the case, 1/100 of a case. Sometimes you need to see bloods, you need to see the maternal situation, you need to see the fetal situation, you need to see the gestation. It is sometimes you read abruption equals delivery. No, abruption doesn't equal delivery. Abruption is a diagnosis, and then you put in a bigger picture abruption plus what? Abruption plus DIC. Okay, if you deliver immediately, you will kill the woman. So abruption plus DIC, you need to correct the DIC. And then the woman lives because the woman is the first one. Abruption with an IUD. Do you deliver? No, not yet, till you correct the DIC, and so on. So we need to be very careful about the word abruption as a big topic and saying, oh, every abruption needs delivery. That is not right. Clinical scenario plus CTG plus bloods plus gestation plus SGA or fully grown plus diabetes or not plus choreo or not, it is a big thing. That's why I feel that always obstetric is art, not only 1+1 or something that you can put easily in an algorithm and say 1 + 1 + 1, and if so, do so, and if so, do so. So yeah, just to keep in mind things that whenever you are doing risk cases, when you are reviewing cases, that you see the bigger scenario, the bigger clinical picture, and also the decision of the woman. As in this case, we put it to her as Montgomery, up to showing the same video of this CTG to one of the big consultants in St. George's. And again, he was saying it is a very difficult situation. If you deliver, you might condemn this baby to death. And if we don't, you will have an IUD. And put it to the woman, to the point that we are involving the woman herself, the woman and the partner and whatever. So it is not as simple in obstetrics. You need to have the helicopter view rather than a microscope view of a small piece.
Thank you, Naguib. Does anybody have any other comments on this case at all?
Cara, there are some comments in the chat.
If someone could read them to me, that would be great. Because I can't see them.
On the chat, there is some comments. Dagmar said 26 weeks, previous PET, SGA, lead booker at 13, attends with APH and OBS, reports pain on and off, bedside scan, breach and hydramnios. So the clinical impression is abruption, no, question mark. If we have that clinical picture and a baby with compromise, can we, number one, await events, risk of IUD, maternal compromise? 2, await action, i.e. steroids, magnesium sulfate, tertiary unit rather than ex utero transfer. I gather an MDT discussion found place, and none would think this is feasible. Yeah, and they didn't think it's feasible. 3, delivery is then the only way despite prematurity, no, question mark. Prematurity, preterm rupture of membrane, abruption, infection go hand in hand. May I inquire if the baby was SGA, question mark.
Yes, the baby was SGA.
And then Bhavna said abruption does not mean you need delivery. Abruption, if mild, can be managed conservatively. Still, diagnosis of antepartum hemorrhage will be abruption. Then Dagmar said, how is the baby now?
Baby is doing well. Baby was SGA. I think baby was on like the 2.1st centile. Weighed only sort of 8 800 to 900 grams, I believe. But baby, the latest report I've heard is that baby's doing well, as expected for a 26-week baby. Baby's still at a tertiary unit. I think there is possible question as to whether or not they'll come back at some point soon. But yeah, from what I hear, we're doing good at the moment, which is great.
From what I heard as well, I think the baby, I don't know whether it underwent or was going or had it, or was it just a suggestion that the baby has volvulus and was about to be having abdominal operation. So I'm not sure about whether this was a suggestion or whether it was a diagnosis and it was operated or not.
Mr. Naguib, for those that don't know, what's volvulus?
So volvulus is where the bowel turn on itself. So if when you are studying the embryology and how baby is having the formation inside the abdomen or inside the uterus, there is some sort of rotation of the bowel happens anatomically and physiologically, and then till the bowel more or less settles. This is in very simplistic form. So when the bowel is turning around each other and causing obstruction, this is where the volvulus is. So whether this was a part of the baby still in the phase of the rotation of the bowels of volvulus, or whether it is a real volvulus because of prematurity, or whether whatever. So again, prematurity was so yeah. Dagmar said, tricky clinical scenario given that the team was between a rock and hard place and managed MDD discussion and getting women involved in decision making. Well done to the team. This is Dagmar.
Perfect. Yeah, I definitely agree with Dagmar here. I think this was incredibly well thought out, and it's very well documented as well as to the whole MDT team coming together. So yeah, good work, guys, if you were involved in the case. Perfect.
No, it is a very well done and very presented from you, Cara, as well, and from your student. And thank you. And I can't emphasize more, as Cara said, about the palpation, about the clinical scenario. We had recently some presentation of cases where a pushing lady was left because of handover time, and so on. So please, obstetrics is not 1+1. It is not choreo means delivery. It is maybe choreo is 9 centimeters fully, and she can have 1 hour of pushing. She can have, maybe the instrumental will be difficult, maybe this. So abruption is a big thing. Similarly, many things in obstetrics is not as obvious as it is. We need to have all the factors involved and all the documentation possible. So yes, thank you very much.
Absolutely. And I think the whole MDT side of things as well, it just goes to show you how important it is to sort of escalate and have these conversations all together, and including the women in these decisions as well. Because I think sometimes we get so fixated and so sort of hyper focused on one singular factor that we actually forget this isn't just about the CTG and what our plan is as a medical team. This is about making sure the woman's involved in the care too, which I think was excellent in this. So yeah, thank you so much, everybody. I hope you enjoyed that one.
Thank you. We did.
Good. All right, guys, we'll see you next week.
Thank you.